H, two arrows up or something saying really high. This may say this one's H with two arrows up saying this high. This may say H, this one's high. This one's low, sorry. And so it's gonna say, okay, all this lighten up, what's going on? Well, if you look at this number right here, remember your bicarb change is slower. So this is going to tell you that there's a chronic component built into this patient's problem. So we look at this bicarb and we say, okay, they're usually retaining some CO2. So let's say they may be a 7.40 when they're at 55 and 30. But right now they're 20 above their normal. So that's throwing them in the acidotic state. You know it's been going over a long period of time because of this. So this was what I would call acute on, or I put / chronic respiratory failure. Insufficiency, whatever. So in this case, yeah, I'm going to call the physician about it. I'm going to take a look at the patient. Usually in this case, BiPAP can bring them out. We'd like to try to put BiPAP on a lot of COPD patients to get them turned around so that we don't have to put them on a ventilator because they are extremely difficult to wean and extubate. So we'd like to try BiPAP in this situation. Now, one pretty cool equation you can look at, you can say, well, you know, what the heck would their normal CO2 be? You know, I have this. So how in the heck do we calculate a normal CO2 for that bicarb? So, now this is just if you're kind of a arterial blood gas dork, you get into this stuff. Most people don't really care. But one little cool equation Dr. Tieram had taught us was trying to find what your predicted CO2, predicted normal CO2 would be in this situation. So you take the bicarb times 1.5 plus 8, and that's just a general equation. It's called the Winters equation, actually, and that's going to give you what CO2 it would take to get a 7.40. So that's kind of interesting to look at because you can say, I'm going to put this patient on a BiPAP because I want to blow off CO2, but how much CO2 do I want to blow off? You can find out there. So that's what, 45 plus 8 equals, I took a wild guess and I think I was somewhat right, 53. So a normal CO2 is 53 if they have an HCO3 of 30. So we know that we're out of range right now, but we don't want to get it necessarily back down to 40. We want to get it to 53. So one pretty good equation there. Now there's one last one I'll go over. I lied. I said that was the last one, but there's one more that we see a lot of. We see a lot of these in patients that are really healthy, come in for their pre-op blood gases. And let's say we send a rook down to stick them. Not that, you know, respiratory therapists usually pretty good sticking, but let's say we have one of these 7 point. I see this all the time. So you say, okay, well, we're looking at this stuff. Let's see what's here. We have a alkalinic. Okay, this is low, so this is alkalinic. This is normal. This is normal. So this is going to be an uncomp respiratory alkalosis. So, all right, so the main time you're going to see a blood gas like this, and I'm going to say if the patient looks healthy, what's happening is when you're going to stick them for their blood gas, their respiratory rate goes from normal, which is 12 to 20, to about 30. So they start breathing faster than normal, and they blow off more CO2, causing them to be alkalinic. Am I worried about this? No. If this happens over a long period of time, yeah, I'm going to be worried about it. How do I know it's not happening over a long period of time? This is normal. This is normal range. So I know that it's a kind of an acute thing. This is to be acute hyperventilation. So yeah, this is going to be out of whack in this situation, but we're in a respiratory alkalosis, and contact respiratory therapist that time, maybe they took a while to stick. Maybe the patient was a difficult stick, or maybe the patient just needs a little bit of vitamin A therapy or whatever you give them up there to kind of chill them out a little bit. So that's about it for respiratory ABGs. If you have any questions, please email me. My email, I'll put it up here on the board. I'm open to doing any subject that comes along with ABGs, or any questions you have about them at all. Jim McCann at uhhg.org. Any questions you have, or any thoughts, or any other specific areas you'd like me to go into, I wouldn't mind doing that at all for you. So just please let me know. And thanks for listening.